We are going to go ahead and move on. We've been having a pretty good clip going here today. So our next presentation, let me get my bio here. Our next presentation is actually from a return speaker, Shacara Thompson-Curry. And if you remember the name, that is Nita Thompson's daughter. Shacara currently lives in Orlando with her husband of 2 years, so if you haven't said congratulations, please do. Staying busy is something that runs deep in her blood, and she holds many titles as a result. Shacara is a registered pharmacist, is a health coach, a diabetes educator, and a business owner. She's earned her doctorate in pharmacy from Florida A&M University in 2010. Has a master's in business administration from St. Leo University in 2016. And for the past 3 years, Shacara has worked in the specialty pharmacy setting. She holds the title of a clinical account executive, where she serves as the clinical consultant on an account management team. Prior to this role, she worked as a clinical pharmacist specializing in pulmonary hypertension. Passionate about educating patients and motivating others to push towards better health, she has decided to start a health and wellness business which promotes improved health for the mind, body, and soul. Very busy woman, please welcome Shacara Thompson-Curry.
Hello, everybody. Hello. All right, I have to get my notes all set up so I can flow for y'all. And I hear it's after lunch, so I will try to keep it lively. All right. As lively as pulmonary hypertension can get. All right, so a little bit about myself. I love what I do. I'm excited when people are interested in what I do, so don't be quiet. If it's something that's like an aha moment, say, that sounds interesting. Or if you have questions, if I'm going too fast, say, wait, rewind that, and I'll back it up and repeat it and do whatever I have to do to break it down, all right? Cool, all right. So by the end of this presentation, I want you all to be able to explain the definition of pulmonary hypertension, describe the impact that PAH has on those with the condition, and then also be able to kind of discuss therapy options for management and understand the significance of the different classes of these medications. So I found this image and thought it was pretty cool, and it kind of breaks down exactly the categories of pulmonary hypertension. So the World Health Organization decided to break up pulmonary hypertension into 5 sections. And basically, pulmonary hypertension is exactly what it sounds like. It's high blood pressure in the arteries of the lungs, okay? And so the pressure is above 25. And so these categories are broken up by how the origin of this condition, the blood flow of the condition, and also it's broken up by the management, how you manage the condition, because each group is treated differently with therapy. So what we're going to do today is focus on group 1, and that's pulmonary arterial hypertension. All right, so what is going on with pulmonary hypertension? Down here is an image of the arteries. So basically, the arteries in your lung are progressively remodeling, okay? So this shows a normal flow of the arteries. So the blood is flowing naturally, got good stuff going on, your blood is being oxygenated. Then all of a sudden, we have some vasoconstriction. So now your blood is not flowing as well. It then can also lead to having vascular lesions, or you have some obstruction in your arteries. And so because the blood is not flowing the way it should, then the pulmonary vascular resistance is elevated. And this causes the heart to have to work harder, causing right ventricle failure. Okay? So that's simple. All right. Now, I've been going through this presentation for weeks. I didn't want this next. I want this next. So we're going to skip and go to this one. All right? Because I want you guys to see a visual of and understand how the heart impact the lungs, okay? So the right side of the heart, this is a normal heart and lung here. So the right side of the heart is pumping blood to the lungs to be oxygenated. Then that oxygenated blood is going to the left side of the heart. The left side of the heart is then providing your whole body with oxygenated blood so you can function. And it's just a cycle that goes on and on. Pulmonary hypertension patients, on the other end, you see how the vessels are very constricted. So the blood is not flowing the way it should, right? And so because it's not flowing the way it should, the right side of the heart is pumping extremely hard. And it's just like a regular muscle. You work it out all the time, it's going to get large. You work it out all the time, it's going to get tired. It will fail. And that is how, that's what happened with the right ventricular, the right side of the heart. All right, so it starts to try to pump that blood through. The higher the pressure, the harder the heart is trying to pump, and it ends up failing. All right, so where does this pressure come from, though? What causes it, right? So it can be inherited. Different diseases or conditions can cause it. It also can be caused by drugs or toxins. And then there's also another condition called idiopathic pulmonary arterial hypertension, which basically means we have no idea why it happened. It just happened. All right. So now I'm going to go back to the signs and symptoms. I kind of wanted to go over that so then the symptoms kind of make sense, right? So if your blood is not getting, your body is not getting the oxygen that it should, you end up with the bluish lips or bluish skin. You have chest pains. You have fluttering chest sensation, shortness of breath. So these are all the signs and symptoms that a PAH patient has, right? So all of this would be awesome if a patient walked in with all of these symptoms and we could say, oh, you have PAH. That is not what happens. They walk in and they have shortness of breath. So what's going on? Do you have asthma? You know? And that's why this condition is misdiagnosed a lot. Not many clinicians know about it because this condition is extremely rare. As of 2017, they were saying that the new case trends was 1 to 2 cases or people per million per year. In the US, there's only about 30,000 people that have this condition. So there's not many doctors that... That's my husband, y'all. All right, so like I said, not many patients, not many people have this condition. So when they walk into hospitals, people don't know what to do with these people. And they don't understand their medications. They don't understand anything about them. And some of the things that we do normally when we walk into the hospital and we, show some signs and symptoms of, let's say, sepsis, right? You walk into a hospital, you all have protocols that when they walk into the hospital, we're going to fill them up with antibiotics, we're going to fill them up with fluids. That's what we're going to do because they show potential of sepsis that can kill these patients. Okay? So these patients, antibiotics, fine, but fluid, no. Okay? Fluid will cause these patients, it will reverse what you're trying to do. Severe hypotension. These patients can die from too much fluid being forced into them at one time. So that's why I kind of want to bring this topic up to you all. And I also saw some numbers that I kind of wanted to talk to you about because these patients are expensive. They are expensive, and it's expensive on them. Also, I have a lot of patients that they take out credit cards just so they can pay for their medication, or they take out a second mortgage on their home just so they can pay for their medication. And we'll get into the medication soon, but the therapies that these patients are on are life-sustaining medications. So it's either you take your medication and live, or you don't take your medication. So that's how severe this condition is. And I just wanted to tell you, like, the average cost of the ED visits. Now, the data is kind of old because it's not many patients with it. So the earliest number that I could find, most recent, was 2011, and this is an ED visit. It's $592 per patient. Now, just to give you some idea, 2007, it was $273 per patient. So that's a $300 change from 2007 to 2011. So, it's no telling what it is now. And then for an average hospital stay in 2011 was $14,791 per patient. The stays in the hospital range from 1 to 10 days. So it really just depends. All right, and I wanted to get you guys some straws so you can blow through the straw and understand how the impact that it has on these patients and how difficult it is to breathe. Yes, ma'am.
What diagnostic tests determine this diagnosis?
Thank you. Yes. So what they have to do is they have to do a right heart cath. That's the only way that you can determine the pressure. They also do chest X-rays. They may do MRIs, things like that, but they have to have a catheterization done in order to detect the pressure. That's the only way to diagnose it appropriately.
No blood test?
No. Yeah.
No pulmonary function?
You can do all of that, but the only way to actually say that it is pulmonary arterial hypertension, you have to have the right heart cath done. All right. So, getting to therapies. All right, so 20 years ago, there was not one medication available for these patients. Not one at all. Now, we have 12. We have variety. Not really. We have 12, and these 12 work in these 3 pathways. So they work with nitric oxide, prostacyclin, and endothelial, and I'll go into those soon. I don't expect you guys to, well, maybe there'll be a pop quiz at the end, I don't know. All right, so your therapy options. They have oral therapy, they have inhaled, infused, and then here, these are your last resorts, okay? So transplant will be first, before this one here. Transplant, and it will be a lung transplant or a lung and heart transplant. Wow. Okay? This procedure here is not done much in the U.S. at all because they have to put a catheter through your leg, in the vessel of your leg, up to your heart, thread it to your heart, get it between the upper parts of the heart, and that wall is called the septum. At the end of that tube is a balloon. It expands, that balloon expands. That helps to relieve some of the pressure that is in the heart to kind of help with the flow. Like I said, that is not done in the U.S. often at all. All right, so the endothelial pathway. And so the mechanism of action for this one is it blocks the endothelin receptors. So endothelin is, it causes constriction. And so these medications block that, so that way it kind of decreases that constriction that's going on. All right? It's contraindicated in patients that are pregnant. So all of these medications are considered REMS drugs. So basically what that means is that there are certain requirements added to these drugs as far as we have to manage these patients closer, watch them closer. There are certain labs that they may have to do before they can get each prescription. Yes?
What's the life expectancy of someone that has this living without knowing they have this?
And see, that's the thing too, because it progresses aggressively. So these patients that were misdiagnosed and maybe they have asthma, they've been living trying to, use an inhaler or something, and they've, at the same time, their vessels and arteries are, becoming more damaged. So the life expectancy, I think it just kind of varies, but it's not, I can't give you an exact number. I can give you an exact number if I can get back with you with the exact number. But these patients, regardless of being on therapy, these therapies basically just draw it out. Like there's no cure for it at all. It's just basically trying to relieve the pressure from the heart, the hard work from the heart. Okay?
Is this often misdiagnosed for CHF?
Yes, it's misdiagnosed for many things, and yes. Any other questions? All right. So this one here, like I said, is contraindicated with patients with pregnancy because these therapies can interfere with the development of the fetus. So whenever I used to speak with my patients, every month I would have to ask, did you go to your doctor and get a pregnancy test? And it also causes elevated LFT, so liver function. So I had to go and ask every month, did you go to your doctor and have a liver function test done? Okay, so these therapies, these three here, really have an effect on the liver, and the lateris and the trachea mainly are the ones for the pregnancy. All right? I'm sorry. Lateris, trachea, and ophthalmic pregnancy. Lateris and trachea for liver. Okay? Another side effect, headache, anemia and edema. All of these drugs really cause like severe headaches because you're causing these arteries and stuff to get larger, blood is circulating faster, it's causing, and sometimes it can cause these headaches. All right, so then we have the nitric oxide pathway. And so this is basically another avenue of causing vasodilation. All right, and so these are contraindicated in patients that are on nitrate. So people that, I don't know, when you have the chest pains and they have to put the pill on the tongue to dissolve it, they can't take that and this. Okay, it can cause severe hypotension. All right. Side effects again, headaches, flushing, dyspnea, myalgia, epistasis. The drugs here, Revatio, Adcirca, Adempas. So, Revatio at higher doses is Viagra. Adcirca at higher doses is Cialis. And so I would always get these calls from my patients, and they're like, hey, I heard that the medication that I'm taking is Viagra. Can I use it for that? No. So basically, it's in lower doses here. So in higher doses, it's used for that. All right? And I used to also get calls from some of my patients that's like, I don't want to take my medication and go out. I don't want to be embarrassed. And I'm just like, no, you're not taking enough of that. You know, please just take me there. And then also, Adempas is one that you have to titrate up to. So you have to build up. So we give them one dose, 130 days, another dose, higher dose, another 30 days, until they can build up to the dose that they need to be at. And in between these months, we're sending nurses out to their homes because we have to make sure that the patients are tolerating these therapies. So Adempas, if we give them too much, then again, their blood pressure can drop really quickly. So the nurses have to go out and ask, you know, different things, and also check their blood pressure and make sure, and stay with them when they take the first dose and track their blood pressure to make sure everything is okay.
So for how long they take this medication? They have to take it all their life, or they take it for, and if they use for this medication, there is another thing that you do for the patient?
So all of these medications are for the rest of your life. And some, if we catch it early enough, some people might just be on these oral therapies for a little while. As long as these are helping, they'll start off with the oral therapies with these. They're taking about 1 to 2 tablets, maybe 2 to 3 times a day. So these, they can stay on them and take it just as it is, as long as they can, for as long as they're having benefit from it. Does that answer?
Yeah, but if they used to this medication, you have to increase the dose for them or no?
So for these two, we don't have to increase a dose. For this one, we start low and go high each month until we get to their dose.
I have a question. So you said they take 1 to 2 tablets 2 to 3 times a day.
Mhm.
How much is the one bottle of the first one? For 30 days,
You
but
mean like a cost?
like how
Yes.
much would one bottle be
The price of a one
for a
bottle?
30-day supply?
Okay, so it really depends on, yeah.
Insurance, yeah.
Depends on insurance. And so some people I have, their insurance covers it completely. Other people, their insurance, they may have a $50 copay. Other people, they may have a $1,000 copay. These medications are extremely expensive. They're extremely, extremely, extremely expensive. But we do have, there are different foundations that are out that help these patients also with the payments of their drugs.
One thing I was gonna say, my mom had pulmonary hypertension, and if you can get, a lot of the insurance companies don't wanna pay for the Cialis and Viagra for women despite however many letters the doctor writes for them. But those are so much cheaper than, she was on the trade clear. And
Okay.
hers was like close to $1,000 a month.
Yeah, it's a lot.
That's sad. So sad.
And so thinking about, these patients, it's like not only are their medications costing them a lot of, it's costing them a lot of money, but these patients are also, they're having a difficult time doing something that we take so for granted, breathing. They can barely breathe. They have a test called a 6-minute walk test. And basically that allows some doctors to kind of see the progression of the condition. And so what they do is have these patients walk for 6 minutes and see how many times they stop, how many times they have to sit down, how far they get in these 6 minutes to kind of say whether the disease is progressing or whether it's maintaining. All right? All right, so now we have the prostacyclin analogs. And so this group of drugs, it increases the vasodilation by replacing prostacyclins which are not being naturally produced in the body. And so these drugs, they come inhaled, infused, and oral. So because they're so different, I just decided to kind of break them up in inhaled, infused, and oral. They're different in the routes of administration. All right. So epoprostenol, the major side effect for this one, jaw pain.
Wow, which is chest pain. Could be a heart attack.
Right, jaw pain, flushing, nausea, diarrhea, skin rashes. This one is an IV formulation. Now, I know some people, when you think IV, right, you're thinking, oh, they're going to the hospital to get this done, right? No, they're mixing and infusing themselves. And actually, they're wearing a pump because these drugs have to be given 24/7. All right, so these pumps, they have, and this one, the Flolan, which was actually the first version of the epoprostenol, the Flolan has to be iced. So not only are they walking around with the pump and pumping the medications, but they also have an ice pack on their pump so that their medication can stay fresh. And I wanted to I put this image up here because that's what a patient's home looked like. They have like a miniature pharmacy in their home so that they can infuse themselves. So we send nurses to their homes to teach them how to mix these therapies and how to infuse them properly. I think I saw, okay.
You always
they always start with the orals before they go to this, or do they see how bad off the heart is before they decide which one?
That's where they have to see how far it is, because you usually want to start off with orals if you catch it soon enough.
Okay.
But because it is misdiagnosed a lot, the disease progressed a lot further than we will want. So sometimes they do have to go here.
Right, yeah.
Saw another question.
Go ahead. I was gonna ask that.
That same question.
What is the age that these people are dying? I'm like, I am and your mother, I'm so proud.
Oh God.
I didn't know that.
What is it, the age that this starts? When can this start?
Okay, so usually these patients are older. They're usually women, and they're usually 60-ish is the normal range. However, I have had patients that are in their 20s. I have had patients that, and what's, I should have put that in the front, but these patients, they should not become pregnant. So not even just because of the medication, but because of the condition itself. The body is struggling to give its own self oxygen, let alone a fetus. So these young people that are diagnosed with PAH, they're not supposed to, have kids and all of that either.
I'm really trying to visualize this pump. What does the pump look like?
The pump, I think I have, this is an example of one of the pumps. So
Is that something inside or outside?
it's outside,
Okay.
yeah. And so this is the case, it flips closed.
Flip phone.
Like a flip phone.
You just, yes. So in our things that we ship them a little pouch. It's like a fanny pack. And that's what they have their pump in.
Is PAH linked to your lifestyle?
So PAH itself, no. Pulmonary hypertension, you saw in the beginning when they have all those groups, that's another situation. Yeah.
Did we go over what causes that?
For the PAH,
Oh, pulmonary hypertension. What's
yeah.
PAH?
So PAH can be caused by, it can be inherited. It can be caused by different drugs or toxins. I had one of my patients, he used to work in the mines and stuff. Yes, PAH. It can also, they have no idea, that's
They have no
idiopathic.
idea? Okay.
Yeah. And then it can also come from different diseases. So like some HIV patients have PAH.
So so is any of that then, and I know that you said that the typical patient is older, but in the younger ones, does any of that seem to relate to congenital heart problems?
Yes, but then also inherited also relates to that also.
So not just the genes, but it can be some kind of congenital.
Any questions? Any other questions?
Are there, if you look at a global map, is there incidence of this disease in specific countries or?
Well, now countries I'm not sure of. And then as far as like PAH, I can look to see if there's a certain place that is more popular, more populated with PAH patients. But I just know from my patients, I dealt with patients all over the U.S. They're kind of scattered. So, but I can look and see if there's a place that they're highly populated. Yeah,
Wonder
yeah.
if that's
I can
a
definitely.
driver.
Mm-hmm. Sure, if you want to, write your information down for me, I can look that up for you. All right. Any other questions? All right, I'm gonna go back.
Keep going.
Okay, so I think this is where we were, and so I just want to say the medications over here. When I ship out to my patients, it's usually a box, 2 boxes of medication that we ship out, and that's every month to give them their month supply of needles, of gauzes, of medication. You know, so these patients are, they know exactly what they need, because they'll call and they're like, I need 2 gauzes. I need 2 packs of Band-Aids. You know, they know exactly what they need. They've been trained in how to infuse these therapies.
Does Medicare Part D pay for this?
I'm sorry, I don't
Does
see.
Medicare Part D pay for this, the prescription medication drug?
Yes.
Okay.
So, yes. Because when you start getting into the billing, it's kind of, yeah. Because Part D pays for like all of the orals and things like that. And then when you start getting into these infused things, they start going into like medical billing.
Right, that would be.
All right. Okay. Treprostinil is another one. And so the common side effects here, you have cough, headache, nausea, flushing, and dizziness. In the formulation, it comes in, you can inhale, infuse. Here we have IV and under the skin. And also now they have an oral form. And so we have the Tyvaso image over there. And this is what they are inhaling. And so these inhalations are 9 breaths 4 times a day. So each of these can take 2 to 3 minutes. And you're doing that 4 times a day. And so a lot of these patients, they will call and tell us, you know, they have some kind of feeling, you know, of raw in the throat, or they're coughing all the time. That's one of the common side effects of these of the Tyvaso. Orenitram, which is newer. Now, like I said, the medication is continuously infused. So if it has to be continuously infused, how can someone take it by pill, right? Orenitram is extended release. So these patients have to take their therapy on time. No ifs, no buts, no I waited an hour, I waited 2 hours, I missed this dose, I went out of town and left it home. None of that. They have to take it on time. Then another thing with the Orenitram is it comes in so many doses, and the patients, it's like 0.125. 0.25. And the patients don't always know which dose they're taking. So they call and they're like, I need my white pill and my green pill. And that's how they remember it. Because I take 2 white pills and I take 1 green pill. And at night, I take 1 green pill and I take 1 yellow pill. And that's how they know it, because it's so complicated. And that's how we're trained to be able to know it, because we have to be able to communicate and teach them how to take these therapies. Another thing, a lot of my patients, when they were taken off of these infusions and put on the oral form, a lot of them went back to wanting to be on the infused. Just because initially that oral therapy gave so much side effects, so many side effects. They were tired all the time. They were having really bad headaches and things like that. But I believe it's just because, you know, they were used to taking that Remodulin, they were used to taking that infusion, and then it kind of changed and it kind of, you know, wobbled the doses a little bit. So we usually encourage them to try to stick through it for a little bit longer and see if they start to feel better. And if not, then we switch them back. And Iloprost is another inhalation, and again, cough, headache, flushing, and jaw pain. And so Ventavis is this inhalation form. And so this one, they're using 6 to 9 inhalations daily during waking hours, and each inhalation is 8 to 10 minutes. This here is another one, Uptravi. This one is very new. And it also has the side effects of headache, joint pain, jaw pain, nausea, vomiting, diarrhea. So with Uptravi, they start at the 200, and our goal is to get them to 1600. So they're increasing every couple of weeks or every few days. We're trying to get them to increase their therapy so they can get to this goal 1600. I have very few patients that are on the 1600. Some of them are able to get to 800, and that is it. 1000, and that is it. And it's just because of the side effects of these therapies. And doctors really want them to at least just stay on the therapy and not take it. Stay on the therapy instead of not taking it. So they're just, whatever dose they can get to, just let them get there and let them stay there. Because taking something is better than taking nothing at all. All right, and then this is just like a zoom in, just zoomed all in into our arteries. Isn't it beautiful? And so basically it just shows each pathway that I just went over. So the endothelial pathway, the nitric oxide pathway, and prostacyclin. So I just wanted to put this image here so you can know that they're all actually working in those arteries. All of the medications we just went over. Oh, sorry, question.
How do you know which one to give what patient? I mean, is there one works better than the other one, or does it, one has less side effects on them than the other one, or do they build up a tolerance, or?
So each of the therapies, they kind of vary, and I say this is pharmacy all the way to me anyway. It's kind of, I'm gonna put you on this, see if it works. If it doesn't, we want to put you on this and see if it works. If it doesn't. Now, in some cases, there are very logical reasons. I'm talking about pharmacy in general. There are very logical reasons why doctors choose certain therapies. But for pulmonary hypertension, we're going to go with, we're going to try you on an oral therapy. We're going to see if it works. If you're on some type of heart medication that you can't get off, then we're going to go this way. If you're not, then we can try you on the Revatio. So things like that. So it's not really a definite way to go. It's kind of up to the prescriber and the patient's tolerance.
In this?
Yeah.
Do they ever do combinations of these things?
Oh, yes. Yes. A lot of times they don't stop one to start another. They just add on to. So if you started off with Terrace, and now we need you to use Vitellis, you're going to go to inhalation. Now, sometimes they do go from inhalation to, off of the inhalation to infuse. So, but most of the time, if they're on oral, they may be on oral and inhalation or oral and infused. Any other questions?
So after you're diagnosed, there is no other way of determining your current condition other than that cardiac cath?
Yes, you have to do a right heart cath because that's the only way you can measure the pressure.
But then afterwards, knowing how aggressive or not aggressive the disease is, there's no other nuclear med, any other diagnostic test?
Now, to test for like progression and things like that, they do just take images of your heart, images of your lungs, things like that.
Okay.
So the right heart cath is basically just to diagnose.
Okay.
And then they also have the 6-minute walk test that I was telling you about also. Any other questions?
Given that it is so commonly misdiagnosed, is there, I mean, it may not be, but is there an estimate on what the more actual number might be? Since you said it's a fairly rare disease, is it possible it's slightly more common? Well, not common, but how many missed cases?
It could be because a study that I was reading, when the patients were finally transitioned to a specialist, a third of them were misdiagnosed.
Wow.
Yeah.
How do
Congratulations. How did you end up in pulmonary?
And pulmonary hypertension.
Yeah.
Yes.
You know what?
I don't know.
Honestly, because I when I first got out of school, I worked at CVS for 5 years. I was doing retail pharmacy. I really wanted to get out of those 14-hour shifts. And so I started looking for something that I can get off of my feet for 14 hours, and I kind of just fell into specialty, honestly. I thought I was applying for this position for something else, and when they called for my interview, they were like, oh no, it's pulmonary hypertension. I was like, oh, cool, all right, well, you gotta teach me that. Because pulmonary hypertension is not something that's taught at all. So in pharmacy school, all I learned about pulmonary hypertension is that they take Viagra and they take Cialis. That's all I knew. And so when I got this job, they really trained us, and I just kind of fell in love with it and the patients.
Does this ever happen in children, and so is the protocol for therapy the same as in adults?
There are some children. I do have some babies, and they have that Revatio formulation. It comes in a suspension. You can make it into a liquid, and so they usually take those liquids.
And is the inhalation almost like a nebulizer?
So yes.
Are they put on like an organ transplant list like right away? Because I mean, it's not something that's ever going to cure.
Not right away.
The condition has to
It has
worsen.
to progress because you don't know when.
Right.
You know.
And it's eventually gonna.
Yeah.
It doesn't get better, and does it stay the same with the medications?
Yeah, and that's what the
Okay.
medications are for, is to try to help them maintain as long as possible. Yeah.
Is there any ethnicity that it's more prevalent in? Any ethnicity that it's more prevalent in?
Yes. So it is more prevalent in white women. All the way in the back first. You right here, yeah.
What age group?
Usually, they're usually diagnosed around 60. In the 60s are the main that we see.
Is weight a factor?
Weight is not a factor. Okay. Yeah.
I was just gonna say, like I said, from personal experience, my mom actually developed pulmonary hypertension because she first had scleroderma. And I think a lot of times, it's more of a secondary. I mean, you can have the primary, or like you said, the idiopathic.
Primary, right.
But a lot of times it is secondary, and if it's secondary to another condition, then the potential for transplant is even lower and more difficult, because then, because a lot of those conditions are autoimmune disorders, and so then they have to take into account that your body can just attack the other organs, so they don't list you or put you very low on the list.
Yeah, that's good.
Our pulmonologists at our hospital are targeting asthmatic women in their 50s and up with other factors, family history in the heart, et cetera, short of breath, all those things. They are targeting them and checking this out, just so you know.
Because they are so frequently misdiagnosed. That's good.
They are paying attention.
That's good. That's good.
She worked.
That's good.
I was actually going to ask, so that's a really good follow-up question. Is it something that's becoming, like, more, people are being more educated on it?
I think people are paying more attention to it because it is so commonly misdiagnosed. So I think it is something that's, that some people are being aware of. In this role, as as a PH pharmacist, we have to be on call. So we would take it every few weekends where we have to be on call, and I would get calls 3 o'clock in the morning from a doctor that has no idea what to do with this patient. They said they were on Remodulin, and go tell me what I'm supposed to do.
Oh, wow.
Because they don't know.
Wow.
Okay, true life story. I come in and I'm supervising, right? And one of my nurses is in the emergency room with all my nurses. So I go over, I'm like, what's going on? She started lip smacking. Oh, it's a story. You want? All right. she started lip smacking. She was sitting in her cubie doing her queries, and she started, you know, and my coworkers looked at her, and she started turning gray. When I tell you, by the time I got there, I went over to the emergency room. She was about this color gray. I've never seen anything like it. She's fair with freckles. She's 55 years old. Never been, no problems. I mean, she's a little, you know, heavy, you know, like all of us. And she got diagnosed with this. They couldn't get her pressures down. Guess what they did? They threw her on her back, they put her feet up, and made her blow into a syringe. That's why you're going to do the straw thing, weren't you?
Yeah.
And it brought her pressures down. Wow. But I mean, it just came on like that. And she's young. Yeah, so
Never
it was
had
like
any other problems?
no other problems. So one of the things that I probably went over it, if I missed it, I'm sorry. Fluid restrictions. They had to put her on major, it's like she had to only drink, I can't tell you how much.
Because they,
So much water a day. So much water, like half a cup or something a day. It's like no salt, came off the salt.
so does she also have heart failure as well?
Nothing. She's never had anything. All she noticed was a little swelling in her knuckles. So they were doing the workup for scleroderma. That's all negative. So she got diagnosed with this PAH. So I was like, oh man, you should have been here. She's talking all about it.
Yeah.
So yeah, it just happened. Like she came into work. It's like you can sit right there and just boom, she's done. Yeah.
Scary.
Yeah. So we always tease with the lateras because now she's 55. She has to get pregnancy tests all the time.
Yes.
So she goes, yes, I don't want a lateras baby.
And people would get so mad.
She's
when I would ask.
yeah, they have to get pregnancy tests all the time.
Mm-hmm.
What else does she have to do?
And probably liver function tests.
Liver functions. What else? And I tease her about the Viagra. But yeah, that was scary.
But
I
she's
was
still
like,
working.
Oh yeah, she better work. She's really nice. Pregnancy test, 55 years
And
old.
Viagra,
Get rid of Viagra.
Here, take your
I had a
Viagra.
new
Give me
boyfriend. Oh,
pregnancy
boy.
Right.
Talk about a joke from God.
Yeah,
Oh,
really.
my
Yeah.
Yeah, we have to
Yeah,
ask
so-
about the pregnancy test, even if you tell
She goes,
us.
I have to get off. I have to go get my
Yep.
pregnancy test. I'm looking at, really?
Yeah,
She goes, yeah.
have to have it done until we get something that says that you cannot
Wow.
become pregnant.
Not even menopause.
No, but
You
she
have
was,
to be done
so
over
what,
and out. The doctor says you are
I
done.
had, being a nurse for a long time, I have never seen anybody turn that shade of gray and come back. That was the first thing. I was like, her tips of her fingers were gray. I was like, ooh, what, you know, I was like, look at that, I'm freaking out, you know, but, yeah, so, wow. Very good.
All right, so that is the end. I just had this here just to show kind of what we went over. And so it is extremely rare condition and it's commonly misdiagnosed. And many clinicians are not familiar with it. So there are some things that are going on. I'm glad to hear about that, what's going on with your hospital. Life-sustaining treatments, they have to be on these treatments, on those infused medications. The half-life of those drugs are so short, like 6 minutes. So if they're off of the medication for too long, they can have rebound going on and have severe hypotension and things of that nature, and their PAH can return with a vengeance. So if they have, one thing that I wanted to say, if they have like, because they're on these pumps, right? And so if the pump has a malfunction or things like that, we always supply them with the extra pump so that way they can switch them out. But those things like that you think about, you gotta think about batteries, you know, because if the batteries die, the medication is not pumping. So these are all things that you have to think about as a pulmonary hypertension patient. And it's very expensive, complicated routes of administration, and currently there is not a cure. So we just try to just maintain the condition as best as